Good afternoon. Thanks for joining us. My name is Bethany Hedden-Clayton, and I'm the Federal Grants Manager at the Center for Behavioral Health and Justice. It's a community-based research center that provides local communities, organizations, behavioral health, and law enforcement agencies across Michigan with technical assistance, evaluation, and support to optimize diversion of individuals from jail and prison through the implementation of best and innovative practices at every intercept of the criminal justice continuum. During the presentation today, audiovisual capabilities have been turned off for attendees to limit distractions throughout the presentation, but we encourage you to ask questions to the presenters. You can raise your hand or enter a question in the Q&A box on your screen at any time, and we will address questions as time permits at the roundtable discussion portion of the event at the end. This training will focus on the benefits of implementing harm reduction principles for law enforcement. We are joined today by Dr. Jodi Swain and Dr. Brandon Del Pozo. Next slide, please. Dr. Swain serves as the manager for clinical risk and patient safety for McLaren Medical Group. She did her dissertation on the need for screening for substance use disorder in ambulatory settings. She has a BSN from University of Wisconsin, an MB from Baker University, and an MSN and DNP from Grand Canyon University. She is an independent consultant for the State of Michigan Licensing and Regulation Department, an adjunct professor at Cornerstone University, and the co-owner of Sudden Resources, a business designed to support SUD education. Dr. Swain has worked as a director, manager, nurse educator, prison RN, clinical nurse specialist, and risk manager. She is a member of the Michigan Society of Risk Management since 2020 and is a certified legal nurse consultant, certified professional inpatient safety, and certified nurse managed leader. Welcome, Dr. Swain. We are also joined by Dr. Brandon Del Pozo. He's an assistant professor at Brown University, conducts NIH-funded research at the intersection of public health, public safety, and justice. He focuses on substance use, the overdose crisis, and violence. Prior to his research career, Dr. Del Pozo served as a police officer for 23 years. 19 of these were spent in the New York City Police Department, where he started on patrol in East Flatbush, Brooklyn, went on to command 2 patrol precincts in Manhattan and the Bronx. He also spent 4 years as chief of police of Burlington, Vermont, where he directed the city's interdisciplinary response to the opioid crisis. His efforts were associated with a substantial and sustained reduction in opioid overdose deaths. Dr. Del Pozo's popular writing has been featured in the New York Times, Washington Post, Boston Globe, Philadelphia Inquirer, Chicago Tribune, Vital City, and the New York Daily News. Dr. Del Pozo's book, The Police and the State, Security, Social Cooperation, and the Public Good, was recently published by Cambridge University Press. Welcome, Dr. Del Pozo. First, we'll hear from Dr. Swain, and then we'll hear from Dr. Del Pozo and follow up with Q&A. I'll pass it over to Dr. Swain now.
Thank you so much, Bethany. I am really excited to be here, and good afternoon to everyone who's taken some time to carve out and learn a little bit more about substance use disorders and how that impacts your work and harm reductions. Next slide. So outcomes, the nurse educator in me just really can't do a presentation without putting up here the expectations so we can receive this information, understand a little bit more about the biology of addiction, understand what harm reduction is and what it is not. Next slide. So addiction, it's treatable chronic medical disease and it has complex interactions. I think the important thing is to really understand how it affects the brain, the genetics, environment, and how all that plays in together. The next slide. So DSM-5 criteria. So DSM-5 is the Diagnostic and Statistical Manual of Mental Disorders, and addiction is considered a mental disorder now. So the point to make on this is that people who are struggling with a substance use disorder, they're going to present at different levels. You often in law enforcement are seeing it when it's very escalated, but they're using more of whatever their substance is. They have not been able to cut back. They spend a lot of time thinking about it, procuring it, losing time, sleeping, missing work. They don't fulfill their life obligations. They don't stop when things happen, like they are arrested. Their family doesn't want them around. They are living in their cars, those kind of things. They're giving up things that used to be important, regardless of the hazard of them. They keep using. They have this incredible craving. They're developing tolerance, and they're experiencing withdrawal. And I want to talk to you a little bit more about those medical pieces with it. But we can move to the next slide. What ASAM says, and this is the American Society of Addiction Medicine, is that people with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. The next slide. The prevention efforts and treatment approaches for addiction are generally as successful as for those with other chronic diseases. If there's a couple little nuggets that you can take away from today, is that addiction is a chronic disease. It is under our mental health work, so it's not under your physical issues like you have, diabetes and heart disease, but it is seen as a chronic medical disorder. And why do we look at it that way? Let's move to the next slide. So this has a lot of excessive medical words in it, but the areas of the brain, I wanted you to focus that there's an area that is the anticipation of being able to use the substance, then the binging or the intoxication, the high, the actual opioid release and what that feels like in the body. And then there is the coming down or the withdrawal and that negative effect, and how that is circular and circular and circular, and it just keeps happening. The withdrawal piece specifically, I've had people who are coming off of their chosen substance, generally a type of opioid, say that it feels like their bones are coming out through their skin. Now, it's probably quite a visual, but I was told in nursing school that aside from childbirth, the most painful experience an adult could ever have is breaking a major bone. So when you hear somebody say that withdrawal feels like their bones are coming through their skin, that has to be up there in the worst pain you've ever felt type of explanation. And the next slide. How addiction happens. And this looks complicated, and I'm going to try to boil it down for some understanding. It's labeled as the biology of addiction. Over to the left, you have these environmental epigenetics, the social determinants. So you have all these things that are creating the opportunity or molding the person that is using. So is it their environment? Do they have access? Have they seen all of this modeled before? What is happening? Do they have childhood traumas that they're trying to not feel? So all these things set them up for what is on the left, the biology or the genes and the development. And there are hundreds of genes that participate in creating a actual addiction. So then there's the use of the drug or the alcohol, there's the use of the substance, and because of the way the brain is set up, then it ended up in a substance use disorder. And I try to boil this down again. So the human brain it's very complex in its frontal function, when we're using our very high executive thought. But we have a part of our brain that's very basic, and it's going to run off of three things in life. It is going to run off satiety, or being satiated, being satisfied. It is going to run off of sex, so those positive feelings and procreation. And it's also going to run off of sleep. So are we rested so that we can chase the first two? So when you talk about opioids specifically, because I think that's really where a lot of our focus is, and the focus of our conversation today, opioids are in our body all the time. We have our own version, our own body makes it, sustains it. There's something called a runner's high. I can't really relate to that. I tried a 5K once and we'll never do it again. But that runner's high is supposed to be this continuous cycle of it felt good, it released it. I got this dopamine hit, which is our opioid center, and this good feeling. It's the same thing that happens, when people hit your like button, or when you see things that are positive reinforcement. So in the world of our basic brain function, we like that feeling. We want to feel it again. It's that cycle. We like the feeling. We want to do it. We think about it. We want to do it again. We come off of it. It's that cycle from the first slide. So let's say that you have a really incredible meal. So we're talking satiety, or it was the best steak you ever had, or you're a big chocolate fan, or whatever it is really something that you found satisfying. That will increase your own body's opioid level or feel good hormones by 10 times. So 3 times. So you're like, oh, I have 3 times as much. That was great. Now, when you move that over in our basic desires, and you talk about sex, and you talk about a climax, and that doesn't last very long, but that will actually increase your opioid, your feel good, by 10 times. And, then you could get into your oxytocin and your need for sleep and that kind of thing. I could make some jokes, but we won't do that here today. So that's 3 times, it's 10 times. Now, if you are a substance user and you are using something like heroin, which is a real basic opioid, that bumps those internal factors 50 times. So you use heroin, you feel 50 times as good as when you didn't, or as you start to withdraw. The other piece with that, when you start going through the brain mechanisms, is that you flood your brain with it, and there's so much of the opioid that your brain goes, wow, I want to feel that more and more. I'm gonna create more places for it to land. So not only do you rewire your habits, you're rewiring your brain, and that drive gets even stronger. So it's 50 times as much. And this is why someone has to use more and use more to get the same level of satisfaction, that same bump, that same high as they did. And how we get into overdosing, and how we get into depressing our respiratory system. And just to stop on that slide, it's 300 times the first time somebody uses meth. So imagine what they're chasing, what their brain has redeveloped into, and what that withdrawal is like. So that is as scientific deep as I'll get on you guys. I don't want to glaze anybody over, but we can move over to the next slide. So some interesting facts about biology of addiction. We can go to the next slide. Here's some numbers. We talked about what's going on in somebody's life. We talked about their genetic predispositions. And then the middle bar was what happens when they introduce their substances. So if you are a woman and you introduce the substance of alcohol into your system, you have a 1 in 24 chance of developing an addiction to that. When all those things align, childhood trauma, genetics, self-esteem issues, genetics, all those kind of things, you are 1 in 24. Now, if you are a male and you introduce alcohol into your system, you are 1 in 12 people that will develop an addiction to it. If you are using cannabis, either gender, 1 in 10 that you will become addicted to how cannabis makes you feel and rewire your brain and drive you into your satiety cycle of that. And if you are using opioids, 1 in 4. And this is why it's such a huge social issue. We thought we had things going on, over the years and years with alcohol addiction. And now 1 in 24 that have been exposed to opioids. And this isn't just, somebody who's parents shoot heroin, so they end up doing it, or, who sneak into grandma's med cabinet. This is your kid who is a star athlete and gets hurt and has surgery and gets opioids introduced to their system, 1 in 4. And it can happen in as fast as a day or 2 that brain rewiring already starts. So I just want you to know this is where people are starting at when healthcare and law enforcement kind of intersect. So next slide. So let's talk about it as a disease. I'm trying to level the playing field that what's going on. Maybe the initial introduction of it to their system was or was not by choice or circumstance or any of those things. It as a disease, what would happen if we treated diabetes the same way that we treat addictions? So you didn't take the medicine that we put you on to help you with your cravings. So, we're not going to take care of you anymore. Weird diabetics they change doses, don't take it, overtake insulin so they can eat half a chocolate cake. They do all kinds of things to try to keep their sugars in line. You didn't get your labs done. You didn't give us a UDS, but diabetics, they don't get labs done. They don't get their hemoglobin A1C, those kind of things. They end up in diabetic ketoacidosis. You didn't go where you were. What if we told them it was their fault? We didn't give them insulin anymore. We told them if they overuse their insulin, they can't have it, and then we told them, you went to the hospital and didn't do that. We're not going to take care of you anymore. So just that kind of care, that kind of stigma and that inconsistency, if people present to an emergency room with a cardiac issue, regardless if you feel like they brought it on themselves, from poor, health habits or anything like that, we don't turn them away. We get them a cardiologist, we get them in, we get them stented, we have a door to cath lab numbers. We do all these things in medicine, but those don't apply to addiction. And we've got some work to do on our end. We can move to the next slide. So harm reduction. Harm reduction, I really like this to say that it's a range of public health policy designed to lessen negative social, physical consequences that are associated with various human behaviors, both legal and illegal. So some examples of harm reduction. Here's a good one, the next slide. And nicotine. So nicotine patches, nicotine gum. We applaud people when they're trying to quit smoking, and some people will chew that their entire lives, and nobody is judgmental. They're like, oh, good, they're not smoking a cigarette, which has all the carcinogenics in it. They're not exhaling it so that other people are exposed. We in medicine like to say the most common form of child abuse is people smoking in a car, with a kid because they don't have any choice. The next one is, there we go. They're sliding in there. So it's caffeine. So caffeine or sugar, really. We have options. People can drink Diet Coke. They can drink Diet Coke without caffeine. We have things that are available. We have, non-alcoholic beer, and we encourage people to wear their seatbelts. We made a law around it to put their kids in car seats. Those are forms of harm reduction, and they're socially acceptable. So we support them. So I'm just trying to challenge this a little bit. Now that we get to opioid use, here's a couple harm reduction techniques. And one of them would be Narcan. SUD specific, really opioid specific. So Narcan can reverse overdoses. Narcan, everyone should have some. There's Good Samaritan laws. Sometimes we need multiple doses, so if people can initiate doses before EMS responds, it's important. We've seen that with the replacement of fentanyl as a synthetic, that there's just a need to use more than one dose to get all of those opioids off of the receptors and have them initiate breathing on their own again. You're starting to see Narcan vending machines, and even some local businesses are willing to keep it in their businesses when their areas around them have a high overdose rate. Another is the next slide. So we talk about needles, alcohol wipes, cotton balls, needle exchanges, and it's more than it's more then making sure that they're using a clean needle. We're removing the ones that have been used from circulation, from being dumped places, and getting them properly disposed. When you take a look at needles to the distribution, the way that they're done, it's generally by people who are familiar with portals of entry into the treatment systems. So we do encourage the needle use. And the last one on here, I have it SUD specific, but I just want to introduce the idea that Suboxone or buprenorphine is also a bit of a harm reduction angle, because it is healing the brain by going on all those open receptors that are doing that drive. And it has to be given by a physician, a provider who's trained. It isn't just specifically something that can be, handed out like, needles. And Narcan is quite well covered with Good Samaritan laws, and has increased in their ability to access as well. So we can advance. And harm reduction, why is it good? So why is harm reduction good for a community? So healthcare is kind of in its own little bubble, or in its own silo, and harm reduction is often done by healthcare adjacent community support groups, other entities, but it's done with people who are highly trained. So they're trained in the area of the different stages of engagement when it comes to therapy. And there's this active use and pre-contemplative, contemplative, preparation, action, maintenance, relapse, back to pre-contemplative. There's a whole cycle that they go through, and people recognize this. Some of the best people in harm reduction can be our peer recovery coaches, because they have been through and are in some stage of substance use disorder treatment, and are in recovery in some way. So they're great. This is often another place that law and healthcare can overlap. Next slide. So why would we want to improve attitudes about harm reduction? Harm reduction overall is good for a community, because they lower the diseases that come in conjunction with our patients who have issues with substance use disorder. So we'll see them at the hospital for heart valve issues, because they've gotten infections, bone infections, site from injection infections. They've had MVAs, they've had near deaths, they've had overdoses that they've been revived from, and all that is going to impact hospital bed availability, healthcare costs, incarceration costs. Harm reduction is going to decrease crime, and it's going to decrease death. And I love, one of the physicians I work with just says, you can't get dead people into treatment. So that's why another reason it's open. It's good for communities. And the next slide. So how to use it and work in life, I'd like to see us be a little bit more open-minded. We're okay with other forms of harm reduction, ones that, make sense, ones that are protecting children and vulnerable adults. And if we could take and apply those same concepts, we're good with, having AEDs in public places, and we're good with things that we deem the audience deserves to be kept safe. And so if there's anything that I can try to challenge, is that these are all human beings, and we all deserve to be as safe as we possibly can, regardless of where we are in our lives. And I'll stay on, and we'll have time for the Q&A at the end if there's anything you'd like me to share, any kind of clarification that I could give. And I will bounce it back to Bethany for our next presenter.
Thank you so much, Dr. Swain. I appreciate your presentation. Let's turn to Dr. Del Pozo. Take it away.
Thank you very much. Can you hear me?
Yes, we can hear you well.
Great. So thanks you. That was a great presentation by Dr. Swain. I love the idea that she talks about buprenorphine and Suboxone being a harm reduction medication. When I was a chief of police, the fact that it actually not only does what the doctor said and help repair damage to the brain, but it also, without diving into it today, it has actually a protective effect. If you are taking buprenorphine, it protects you from overdose from more potent opioids. It was one of the reasons why I decriminalized the possession of buprenorphine without a prescription when I was a chief of police, because I truly believe that if you're taking buprenorphine, it reduces the harms of taking a more potent opioid and reduces the risk of overdose. I was thrilled to hear somebody with that clinical knowledge point out that medication for opioid use disorder can be harm reduction as well, not just treatment. So that said, next slide, please. So I just wanted to acknowledge my funding sources. I'm privileged to be funded to do research and translate knowledge by the National Institute for Drug Abuse. I have no conflicts of interest to declare. Next slide, please. The premise of this talk is that as a form of harm reduction, the deflection of people whose police encounters are driven by addiction to treatment in lieu of arrest advances public health and public safety and is a core role of the police. So what we're going to argue or demonstrate in this presentation is that the alternative of treatment in lieu of arrest is an evidence-based form of harm reduction that also makes communities safer. So there's not really a trade-off in pursuing it. Next slide, please. So one of the things that surprises people, but that doesn't actually surprise me, is that protecting public health is actually a core role of the police. We think of police as law enforcement. We think of police as an entity that advances public safety. All of that is true, but if you go into the New York City Police Charter, which was last revised in 1961, they say explicitly within the charter that the NYPD is chartered to guard the public health. They talk about in that same passage, which is the charter, like basically the constitution of the NYPD, they're charged with the proper protection of human life and health, right? So this is not some alien idea where some like reformist police chief researcher comes out of left field and says you should do something that we never asked you to do before and radically change your role. You can go back into the charter of the New York City Police Department, which the last version is now 50-something, 60 years old. And it says right there, protect public health. So I'm going to argue that this is a job that police have always been tasked with doing. Next slide, please. When it comes to protecting public health, one of the main threats to public health and one of the main threats to safety, if police job have the role of saving lives, overdose is absolutely one of the biggest threats. In fact, we'll get to more data in a second, but it's probably the biggest threat. So next slide, please. Right. Don't stop. Go back. This is the animation. Perfect. So car fatalities rose the fastest clip in half a century, right? That's 46,000. Next, press enter. Homicides, that is the core role of the police. It's in the news all the time, preventing homicides. That had a record increase in 2021. What was that? Next slide, so to speak. 19,400 homicides, right? All right, so please advance. 58,281 is how many people were killed in the entire Vietnam War over 10 years. But yet in 2021, which is this data, it's reliable data, 105,752 people died across the nation from an opioid overdose or a drug overdose generally. So if we're looking at what the biggest threat to public safety is, the biggest threat to life is, we accept that the police protect life, it's overdose. Next slide. So one of the things that the police also do, which makes them good partners with public health and for harm reduction, is they're not just looking to create the safest street in a city. They're not just looking to create the safest block in a city. They're not just looking to create the safest neighborhood in a city. They're looking to create safety throughout their entire jurisdiction, right? The idea of public health is population level increases in health. The idea of policing is population level increases in safety. And when we're talking about overdose death, we're talking about both health and safety. So we're looking for these jurisdiction-wide approaches, not just a boutique approach at one place, like a doctor and a patient or a police car on a block, but an entire safer community. Go ahead, next slide, please. So part of that is prevention, right? When we talk about policing and police reform, they say we need to focus more on prevention, less on reacting to things, right? But not all prevention is created equal. We have tertiary prevention, secondary prevention, and primary prevention. Tertiary prevention is someone's dying of an overdose and you reverse the overdose right then and there, right? Tertiary prevention is there's a group of people out there committing armed robberies. You stop them from committing the next armed robbery. Secondary and primary prevention are about going further upstream, right? They're saying stopping these harms from happening in the first place so you don't have to react to them. So another thing about harm reduction is it really primes the pump for upstream prevention interventions, working your way back up, not only to reversing overdose, but to treatment, not only to like reversing overdose or treatment, but to stop people from using drugs in the first place. It's all part of a continuum of a response, and the police have a role in it. Next slide, please. I call this the psychedelic sideways squid. What it is the criminal justice system in terms of a flowchart. And what you also want to do with harm reduction and policing is work your way upstream. So please press the slide button once. There's a lot of research into what to do when people get re-entered into the community, what to do with community probation, community parole, community corrections, right? But that's after somebody's already been in jail, after they've already committed addiction-related crimes, after they've already been sentenced, after they've already served time. Please go up one more slide. There's a fair amount of research on what to do while somebody's in prison, connecting them with resources and treatment, giving them education, et cetera, trying to correct their opioid use disorder or their substance use disorder. Please go up again, right? So then there's also the question of what to do with drug courts, what to do during the adjudication process. What we want to do to go furthest upstream, go to the last slide, is really figure out the last thing, what the police can do far upstream to stop drug use from having its terrible consequences like overdose and death, and also the related crimes, right? And you can reach a bigger population at the level of the police rather than these more smaller, more, I say, boutique interventions as you go through the process. So you want to go upstream, reach a lot of people, and intervene before things get worse. That's the potential for police and harm reduction. Next slide, please. So this would, involve aligning public safety and public health. And one of the best ways to align public safety and public health is on the common ground of harm reduction. Next slide, please. So there's a spelling error there. I spelled objective wrong and the editors didn't catch it. But one of the things you want to do is understand that policing can sometimes have negative effects, right? If you arrest somebody and send them to jail, you might be getting a criminal off the street. But what you'll also be doing is disrupting a family, taking somebody out of stable housing, maybe making somebody lose their job or have it be harder to get a job. So police, I'm not saying don't arrest people who commit serious crimes, but if there's an alternative that's effective, consider it because it might be less disruptive in the long term. And the other thing is to be careful about what we're measuring. If we're measuring arrests, if we're measuring kilos seized, if we're measuring guns seized, we could think, hey, we're doing a great job. But if those don't translate into lives saved and people in recovery, and communities having a better, more resilient quality of life, then we can have all the arrests and all the kilos and all the guns seized in the world. And we're still, I would argue, not doing our job in delivering public safety. So we have to be mindful of that as we meet the challenges of addiction and overdose. Next slide, please. So one of the most effective things you can do, period, to reduce crime and harm when it comes to addiction and the related criminal behaviors is to get people linked up with medical treatment for opioid use disorder, specifically the medications. That's the buprenorphine Suboxone that Dr. Swain was talking about. That's also methadone. To some extent, it's sometimes Vivitrol. But if there's any one thing that reduces death, it is linkage to medication when it comes to opioid use disorder. Please, next slide. Just as importantly, addiction with treatment with medication not only reduces death and overdose, it reduces crime. This is an old study. This is from 1991, so it's over 30 years old. But this shows that when people are not being treated for addiction, they report being engaged in some type of crime, at least 237.5, I don't know where they get the half day from, a year. Either buying drugs, selling drugs, sex work, fraud, theft, trespass, domestic violence, you name it. They report about 2 out of every 3 days being involved in some sort of criminal activity. You put them on methadone, which is the most potent of the 3 medications for opioid use disorder. And it's not a magic bullet. They don't go down to zero crime, but their crime is reduced by 70 to 80%. Right? And if you told the chief of police, I have an intervention that can reduce crime in your community by up to 80%, they wouldn't say, I demand 100%. They'd say, that's a miracle, let's do it. Well, when it comes to opioid use disorder, this miracle drug is medication. It is methadone and it is buprenorphine. Please go to the next slide. So there's also proof that there's reduced recidivism when you treat people for opioid use disorder after they're arrested for criminal activity. And it goes to something of what Dr. Swain was saying. When you connect somebody to these medications, it allows their brain to repair. It allows them to continue to now to focus their executive function on things like their family, employment, housing, rather than just trying to avoid the next phase of withdrawal. So you're taking a person who's breaking into cars, committing sex work, trespass, dealing drugs, using drugs, committing a lot of crime. Not only are you reducing their probability of overdose by giving them treatment, but you're allowing them to reframe literally the process by which their brain works in order to concentrate on alternatives to crime, like employment, housing, and stable relationships. So this is borne out through studies that medication reduces recidivism in a jail setting. Please, next slide. Now, what this amounts to in policing, so what does this mean for the police? What it means in terms of harm reduction is an alternative to arrest for minor crimes is direct linkage to treatment. Before adjudication, before sentencing, before incarceration, if you can link people to medications for opioid use disorder, you can intervene on the behaviors that cause overdose, and you can intervene on the behaviors that cause crime. Next slide, please. So this is called in the parlance pre-arrest diversion, right? You take a suspect into custody, you transport them to the facility, you screen them, you say, this person's got opioid use disorder. That motivates them breaking into cars, that motivates them shoplifting, that motivates their sex work, right? And then instead of saying, well, go see the judge and go linger in jail, go through withdrawal, detox, maybe overdose, be unemployed or homeless when you get out, you say, we're releasing you today with a direct linkage to treatment. Some of you might be thinking, well, what about the consequences? If you've been a cop for a long time, and I was a cop for 23 years, the misdemeanor court system is an endless revolving door. And even at the height of its consequences, had very few consequences. You'd see people coming in, coming out, coming in, coming out, getting arrested again and again and again. I would argue that letting people go from the station house with a linkage to treatment, even if they don't take advantage of that 4 times, 5 times, still doing better than that misdemeanor revolving door. And the 5th time, if they start taking the treatment, much better off than any misdemeanor court process. That's the win, right? So you want to keep records of having arrested them. You don't just want to let them go into space, but you do want to keep track of how many times you've done it. But I would argue that direct linkage to treatment prior to arraignment is just as effective, if not more so, than that misdemeanor revolving door. Next slide, please. So there's another way to think of this, which is the sequential intercept model. Some of you might know it, so I'll talk about it briefly, then we'll move along for questions and stuff. I'll try to accelerate the pace of this presentation. But there's this long, that sideways psychedelic squid is this other pastel process here, where you start with various intercepts in the criminal justice system. If you're a practitioner, you know it's not linear like this. You know that it's actually cyclical, that people can revert to different parts of the system, go back at any given time, but you want to catch them at the earliest possible intercept before they go deep into the system, before they're going through a court process, before we're paying to incarcerate them with huge amounts of tax dollars. You want to catch them and turn them back towards a linkage to treatment early. Next slide, please. So this is taking hold in a lot of American communities. This is the Law Enforcement Assisted Diversion National Support Bureau's data. You can see like the blue names are locations where some type of diversion program is in effect. The red ones are where it's being implemented at present, and then the purple ones are where it's being considered. Right. And this is updating every day. So this is not some alien practice. There's some places in the Midwest where you could probably do more of it. But if you look, there's a lot of other states where this is an expanding practice, this type of deflection or diversion. Please, next slide. That's the list, right? Exploring, developing, launching, operating. You can see it's taking hold. And this is just the ones that go to the Law Enforcement Assisted Diversion Bureau for support. There's others that aren't even on this list because they're not interacting with LEAD. Please, next slide. One of the challenges is overcoming police, sort of bias. And again, I'm speaking from experience. I hope other officers in the audience would agree. But at 2 a.m, if you're out there and you want to arrest that person and find a reason to do it, you're not going to make anything up, but you'll take advantage of what you know about the situation, what you know about the evidence, and what you know about the process to choose charges over diversion, right? The same way, if you really, really want to cut somebody a break, unless it's a very serious crime, if it's a nonviolent crime, You can almost always find a way to cut someone a break. Officers have tremendous power of discretion, and making sure it's used based on evidence rather than sort of stigma is a very important challenge for diversion to work. Next slide, please. So one of the things that you want to do is make sure that officers have the right incentives. And this is a study I did. We'll get through it and show you what we found. So next slide, please. We looked at like dozens and dozens of police departments in Indiana and Missouri. We asked cops how much control they have over their decisions. We'll just go to the next slide. Next slide, please. And we found that, you know, of the hundreds of almost 200, over 200 cops that reported, the vast majority of police officers say that they have either some control or total control to make arrests and confiscate things like needles or naloxone or drugs during the encounters with people who use drugs. They acknowledge that they do have this choice, right? Because diversion and deflection involves choosing the linkage over the arraignment. And cops say, yeah, I basically have that authority to make a choice like that, right? They say it with all sorts of dimensions of that behavior. And then on the bottom, that little bit of data on the bottom shows that the cops that are most likely to use that discretion to link to treatment and not make arrests are ones who feel that their boss supports it, who feel that their coworkers support it, who feel that their community and friends would support it, who believe it reduces future arrests, and who think it increases trust in the police. If you have that constellation of beliefs, we've shown that you're the type of officer who says, yeah, and in fact, I do believe that I can and will link people to treatment in lieu of arrest. So there needs to be this like culture of support, of understanding the evidence, of knowing that the community supports it, believing it works, and then also that your boss supports it too. Because it turns out that immediate supervisors are one of the biggest determinants of the behavior of street cops. Next slide, please. There's still gaps in the knowledge, right? Like we asked a bunch of cops in St. Louis, does buprenorphine, which is Suboxone, which is what Dr. Swain is talking about, or methadone, does it reduce a patient's criminal activity? Many disagreed. 37% said, don't know. The evidence time and time again is it does. They in fact do. In this case, in the St. Louis setting, only 20% of cops agreed that it does, which is what the evidence says. A third just had no idea. And the majority said either I don't know or I disagree. So there's still work to be done about understanding the evidence for something like diversion to treatment. Please, next slide. So there's also going to be times when arrest is appropriate. I'm not a retired chief of police, not on the street anymore, telling you don't arrest anyone. No, if somebody is a violent criminal, if somebody has a serious felony record, if somebody again and again and again just uses this to get out of arrest and just goes right back to their old behavior, if someone is selling illicit drugs, not to maintain their own addiction, but purely for profit, these probably are not the most appropriate times to divert them to treatment. These are probably best, criminal charging and arraignment, cases. So this is not a cure-all. This is not being told stop arresting people. This is saying sometimes arrest is best. Many, many times, linkage to treatment is a form of harm reduction that's even better. Next slide, please. Right, so you can find guidelines online. We're running out of time, so I don't want to go ahead and dwell on these, but you need to build a system that is at least as efficient and appealing as arrest, right? One of the things about arrest, and I don't know the audience that well, but no matter where you are in law enforcement, you know exactly what to do 24/7, 365 under any conditions to arrest somebody, charge them, and get in front of a judge. Whether you are in the mountains of Idaho, the streets of New York City, the swamps of Florida, the Bourbon Street in New Orleans, if you are making an arrest, no matter who you are, you know how to get that person arraigned. You can't ask a banker's hours linkage to diversion system to compete with that, right? As a cop, you'll say on your activity report, I made 7 arrests this month. They're good arrests. I brought them in front of the judge. These are the charges. If deflection is hard, if it's only during business hours, if you don't get equal credit for doing it, if your boss doesn't support it, if it takes too many resources, if you don't track the outcomes to understand it's working, it can't possibly compete with arrest. And we find in a lot of cases, like in certain jurisdictions, I won't name them, they'll create a diversion system, but not have it count towards productivity credit, not have it be 24/7, have it involve more paperwork than arrest, and have it involve a lot of extra steps for cops. And then they'll say, hey, no one's using it. Well, no, duh. Like I wouldn't use that either back when I was a street cop. So we have to be careful about how we implement this. Next slide, please. Go ahead, next slide. Yeah, I just think that at this point, in the interest of time, I'll wrap up. I just want to make sure, I think there's no more slides. Go to the last one if we have it. In fact, yeah, okay, keep going. Thank you. There we go. So I just say there's a lot of resources out there that we can direct you toward. But if you're looking to reduce the harms of opioid use and the harms of overdose and addiction, and also reduce criminal activity for nonviolent misdemeanors and violations, linkage to medications for opioid use disorder is more effective than simple arrest and arraignment. So thank you very much. I'm sorry I ran a little over, and it would be a pleasure to hear people's questions.
Thank you, Dr. Del Pozo. No, that lands right on time. So we've got 15 minutes for Q&A. Dr. Del Pozo and Dr. Swain, if you want to pop your videos on, feel free to. The first question I have is for Dr. Swain. I think it's related to some of the statistics you provided about the how satiating food, sex, heroin, and meth is in the system. So one of our attendees asked if you could disclose a little bit where that research is coming from and the methods by which those findings were uncovered. I think they wanted to know if it was lab tests or if it was observation or if it's speculation. Just kind of tell us the black box of research for that. It would be helpful.
Black box is a really good way to say that. So that comes from multiple sources. Some published through SAMHSA, some through IHI, different places. I can grab those sources and make them available to this group, but honestly, it's an amalgamation of a lot of things that I put together doing my research around screening for substance use disorder. And I think that the points that I was trying to make with it is, why as humans we're driven to do that, and then what those particular meds do to our brains. But I don't have like the exact, couldn't copy and paste that in for you. I definitely know where to look them up at because I've read them numerous times, but they're some of it is research from lab levels, some of it is research from behavioral studies, and a lot of it is put together through kind of a meta-analysis. So when you take a look at the use versus addictiveness with patients and exposures. So they are published, they're out there, and I'm happy to grab them if somebody wants to know exactly who said that, but they come from reputable sources, not just like, in my 24 people I've met in my life, one of them has an addiction. No, they're studies. They're not even national studies. Some of them are worldwide studies. So I can pull them. Yeah, I'll pull them and make them available if the team wants them.
Thanks, Dr. Swain. Just to emphasize, it sounds like it's empirical data. So it's whatever method it is that's used, it's peer-reviewed and scientific knowledge that has tried to understand how the brain works relative to those various substances and experiences that you outlined. Relatedly, we have another attendee who would like to know the research behind the other statistic you provide, the likelihood of developing addiction. I think you talked about females, the 1 to 24, right. Alcohol 1 to, I can't remember the other ones. But we have another attendee.
Yep. And it's the same. That's data that I pulled, during my addiction research, and then with my partner in my business that we put in there, and she's a certified addiction trained physician. Is we pull those little highlights out to share with people. So I don't want to say, oh, it's IHI, it's SAMHSA, it's but AMA, but it's published and yes, empirical data, not just Jodi observation.
Yeah, great. Thank you. Yes. All right. Our next question I'm going to direct to Dr. Del Pozo. This question is about repeat offender laws. So this attendee asked, how can we get the concept of treating addiction reduces crime versus imprisonment as kind of contextualized by Michigan's repeat offender law, which when they're breaking and entering charges are actually a substance use disorder, but kind of slaps if you will, a big BITCH on someone instead of a little one. So how does, I think, police discretion apply to that? How does the police culture apply to that? What would you say to our attendees based on that question?
Right. That's a great question. Thank you for answering it. And interestingly, I do think that in my case, in my opinion, I talk about nonviolent misdemeanors because I think that they are a clear case, right? Shoplifting or car break-ins, if the complainant is amenable and they understand the evidence, you can link someone to treatment. A burglary is a felony. I personally think that you can do a lot more to stop repeat burglars by linking them to treatment than by throwing away the key in jail. But that is a felony, so that, that's a thing to be more careful about. But that said, right, if you put somebody in jail for decades, you are definitely preventing crime by taking them out of the community. Like, that is the definition of incapacitation. But it comes at a cost. Number one, the direct taxpayer cost. Number two, like, you're disrupting a family. Number three, if they do get out, even after a decade or so, like, they're at elevated risk for relapse and overdose. Now, there's a lot of, the duration of the sentence and everything does matter. But I will say, kind of to reiterate my talking points, especially for lower level offenses, linkage to treatment is one of the most effective ways to get people to desist from criminal activity, in fact, much more so than incarceration. It's not just true because I'm saying it again and again. In my experience in places like Detroit, for example, or New York or LA, the criminal sentences for misdemeanors, when they do happen, are fairly short in any case. It might be a few weeks, it might be a few months, it might be several months. It's not throwing away the key. So what you're doing is taking someone out of circulation for a few months, but when they get back out of jail, they're not getting back to like stable housing and a great job. They're going back to the same situation they came from, but even worse off, right? Soon they relapse, they hang out with their friends, they start using again, they're back into the sex work, back into breaking into cars, etc. So all I'm saying is that when we look at the evidence, if you are diverted to treatment prior to arrest or given treatment while you're in jail, you have a much better outcome for recidivism and criminal activity than if you're just put through the system, business as usual. Does that make sense? And you're asking how to convince people. Like, the evidence goes back to 1991 for methadone, and it's consistently emerging now for buprenorphine.
Thank you. Thank you, Dr. Del Pozo. I'm going to give the next question over to Dr. Swain. I think I have one attendee that disclosed that their experience has been people on MAT have discussed that the withdrawal from MAT being worse than the withdrawal from heroin. I'm wondering if you can share a bit more. This person wants to know the long-term prognosis for those who have been put on MAT.
Truly, there are some people who can never come off of MAT. Now, there might be some social stigma with it. It's this, replacing one addiction with the other, but the healing of the brain and the replacement of feeding those neurons that are hungry for an opioid substance with your medication, your MOUD, and then it has a ceiling effect. There are some people that biologically, they just truly cannot stop that. And in the world of addiction medicine, that's fine. As long as they're fine with it, we are absolutely fine with it. So, external forces will sometimes say to them, oh, well, you're still an addict. But it's the functionality and where they're at on that medication that shouldn't negate the fact that they continue to take it. So, there'll be, people who chew Nicorette for their entire life and never completely go off of nicotine, and and nobody has a negative effect with that. I imagine that they are comparable. It's going to be stronger if you're using a high amount of heroin, but I'm sure it's very comparable when you try to stop taking what is bathing your neurons, no matter what opioid you are coming off of or what medication that you are coming off of. But there shouldn't really be a stigma attached to taking it for their entire life. Who cares? It's working.
No, thank you for saying that, Dr.
Yeah.
Swain. And I wanted to add, and I'm trying to find the site, I'll drop it into the chat, but there are studies that show that the best reduction in all-cause mortality accrue to people who've been on MAT for 5 years or more. That if you can get somebody on buprenorphine or on methadone, and you can keep them on buprenorphine or methadone for up to 5 years, that's when you get the best long-term reductions in not just overdose death, but all types of death, the death that result from other health problems too. So I want to emphasize what Dr. Swain said, which is that it could easily be that this is a multi-year or lifelong treatment. right? And what you're getting is somebody who is stable, who's employed, who can
Yeah.
think about their family, who can stay housed, right? And so, yes, they are dependent on a partial opioid agonist like buprenorphine or full agonist like methadone, but that's better than them being dead. It's better than trying to be quote unquote clean, struggling with that, going into withdrawal and then going into relapse. And I had one of the pivotal moments in my police career was learning after I left New York to be a chief that my next door neighbor in New York State was literally on buprenorphine the entire time I knew him for years, as a friend, as a neighbor, as somebody I hung out with and went to barbecues with. And I said, if that man can be on buprenorphine for years and have a darling family and be a neighbor, like this is a medication that people should have access to.
Right.
Granted, that's anecdotal, but as Dr. Swain says, evidence bears this out too in the
Time and
aggregate.
time again. Right. And you wouldn't tell a diabetic to stop using insulin because they've had enough years that they've been on it, you know, and maybe their, you know, their diet has improved, but regardless, you know, so why do we want to limit the time on this medication?
You wouldn't tell them like, damn it, I expect you to run marathons, lose weight, and stop taking insulin. You'd say, take insulin.
It works.
I encourage you to do other things, but keep taking the insulin if you need it.
Yeah,
Right?
that's another piece of the stigma. And I'd love to see that go away. Maybe we can be a generation that influences that.
Yeah, I think that the person who asked this had a follow-up. What they have experienced is the person who the folks who are on MAT in their experience are receiving that through Medicaid, or it seems probably Medicare as well, and then are ineligible for those social services once they're employed and having a different income level, which makes them not eligible for Medicaid, and then they don't have access to that medication. So I'm wondering if you might.
I would have them speak to their provider about that, and if they're unsure of it, you know, get a hold of even through myself or somebody who does just addiction medicine, because all addiction is covered by Medicaid regardless of the income level in billing in Michigan now. That has been newer in the last few years and definitely should be utilized for, like with COVID. So in the world of, let's say you're pregnant and you have insurance, but your health insurance doesn't have a pregnancy in it, or you're lower income and you're, you know, 100% of all pregnancies are covered in Medicaid. 100% of all substance use disorder can be covered in Medicaid, even if somebody has a stellar healthcare insurance through something else. I mean, they can have the top line of something, but what has to be done is that bill has to be carved out and it has to be done under their the code and applied for it through Medicaid, and they will get 100% of it covered. That has not changed, and that was rolled out maybe in 19 or very early in 20, that Medicaid covers all drug treatment, and it does regardless of income. So they need to pursue that a little bit more, and talk to even on the billing side, or if this is just a concern that they have. I'm doing really well, but if I get off of Medicaid, my medicine won't be paid for, and that would be inaccurate.
We're having some activity in the chat and we won't be able to get to all.
Yeah, I put 3 things in the chat really quick. A link to the paper that shows that long-term multi-year linkage to treatment reduces mortality. Right. And then I put the citations for the 2 papers that recently show opioid use disorder treatment reduces criminal activity. So just wanted to, and if you can't get them because they're behind a paywall, maybe reach out to Bethany or anyone and we'll make sure you get this research.
Yeah, absolutely. In our closing, I just want to acknowledge one of the questions in the chat, I think is a really good call for future research. This person pointed out that the modalities available for opioid use don't parallel what's available for stimulant users. So I just think that if either of you have a word to speak, I know we're right at 2, but I think that's a really good point, and I agree with that person.
Yeah, I hesitated to give the statistics around methamphetamine because there really isn't a access and clear plans around that. I agree, and I know Dr. Pozo is the more researcher in this group, but yeah, we need to do work around stimulants, especially in rural Michigan.
Oh
Mhm.
gosh, it's so hard. It took me years listen, I was a cop, and I say that in a way of being proud of what I did, but I was a law and order person. There are no medications for treating stimulant use disorder. They just don't exist. They're being developed. It'll take decades probably. But ironically, giving people small financial rewards for staying in abstinence-based treatment is the most effective thing out there. And it's been proven again and again and again. And it might take a while to sink in for some folks in the audience, but the evidence is out there. If you give people who were on methamphetamines, for argument's sake, $50 every time they come in and take a urine test and are found to be negative, that actually keeps them off. That little reward, that little affirmation, it's called contingency management, keeps them off of methamphetamines much longer than anything else out there. And in the end, it saves us money because a person on methamphetamines costs this community a lot of money with their behavior. So the cop in me was like, I don't like the idea of rewarding people for just obeying the law and helping themselves. But the evidence is the evidence, and the studies just keep on coming in that's our best bet at the moment. I don't know if Dr. Swain has seen that too, but that's what's going on out there.
Mhm. All right. Well, I'm going to close us out at that. I want to thank you both for sharing your expertise and your time. This is really beneficial to all of our attendees. We'll be sharing out this recording as well as the slides and contact information so you can follow up with us and get connected to Dr. Del Pozo and Dr. Swain. Thanks again. Have a great afternoon.
Great. I'll send some links. Thank you.
Thank you. Bye.